Good morning, good afternoon, and good evening from wherever you're joining us. My name is Geoffrey Jenga, a communications specialist at the International Livestock Research Institute, supporting the One Health Center in Africa. And it's a pleasure to welcome you to today's webinar on climate change and health, the third in a four-part OHRECA webinar series, marking the center's closeout phase. Through this series, we are basically reflecting on OHRECA's achievement, sharing insights from research, and highlighting the program's contribution to strengthening One Health capacity and partnership across Africa. Today's session, we're going to explore the interconnected effects of climate variability and change on health, zoonotic risk, and livestock systems, and showcase adaptive strategies and innovations developed through OHRECA to build resilience at the human, animal, and environmental interface. And to open today's discussion, I'm delighted to invite Bernard Betts, who is a senior scientist here at ILRI, and is also the team leader of the One Health Center in Africa. And Bernard will deliver a 10-minute introductory presentation and is going to highlight OHRECA's objectives and impact pathways, as well as climate change and health as an existential threat, and also the framework used to analyze the impacts that OHRECA has had, and also highlight a few examples of OHRECA studies addressing the climate health answers. Bernard, over to you.
Thanks a lot, Geoffrey. Let me share. I think you have seen my slides. Is the slide visible from your end?
Not yet.
Okay.
Now we can see them.
Right. Yes. So welcome, everybody. I think as Geoffrey said, we are running a series of webinars to really communicate our work from OHRECA, but at the same time, situate the work we have done within many other studies which have been done by other people across the continent. That's why we have a mix of our own presentations together with those of invited panelists. So shortly, let me just focus on a few things. First is OHRECA in full, of course, is One Health Research, Education, and Outreach Center in Africa. In short, it's OHRECA. We established it in 2020 with support from BMZ Germany, specifically to focus on two main objectives. One is to support applied research to develop new knowledge on One Health, but also to support capacity building so that we can then further develop skills and strengthen One Health policies and practices in the continent. We had 3 work packages, which of course combined activities across several thematic areas. This included the evidence that counts as the first work package. And this basically looked at what causes disease hazards using risk-based surveillance frameworks. The second was developing interventions, assessing them, as well as trying to understand how they performed in different settings. And the third was building networks and partnerships with various people, communities, NGOs, training institutions, and multiple centers. You can see on this chart, we also had capacity development cutting across work packages, but also cutting across activities to outputs to impact. And also on the chart, you can see that the main outputs that we generated included evidence, included technical interventions, and included collaborative mechanisms, which aimed to impact on better evidence, better policies, and better practices on One Health. This is another chart showing you the locations where we implemented the work, mainly 8 countries. Those in East Africa listed there: Kenya, Ethiopia, Uganda, Tanzania, and Malawi. We also had Burkina Faso, Mali, and Senegal in the Western region. There were 3 other countries which were co-opted much later, that's including Rwanda, Burundi, and Cote d'Ivoire. And early on in the project, we identified 4 main impact areas. One is developing food safety benchmarks in East African region, also developing AMR action plans in Uganda, supporting One Health platforms across all the countries, and lastly, developing One Health interventions for specific health challenges in specific locations, which we'll be discussing in a short while. I want to emphasize all that today we are not really looking at these impacts. We have another webinar coming up on 12th of November, that's next week, where we will assess the extent to which we achieved all these things which we have listed as our outcome areas. Today, we just want to focus on one main health challenge, that's climate change and health. We have selected this amongst the many that we have done because it's really an emerging area. It's known to really be an existential threat, as Geoffrey said. And the approach that we used mainly a three-pronged stepwise process. So the first was basically to generate evidence on the linkages between climate and health. That's the first step. And this linkage should be adjusted for several predictors. So we're using multivariable models, prediction models, to really obtain that refined estimates of impact of various climate variables on health. The second step that we needed to do is to forecast the estimate, the health risks into using future climate scenarios. And this, of course, we know that there are so many data sets that can be used to do this forecasting, basically to understand how would the future health burden change as climate changes. And lastly, policy dialogues. And I'm happy that my colleagues who are the panelists will be covering some of these topics in detail. So let me start focus on specific evidence which OHRECA generated from the four focus areas that I've spoken about. So the first is on AMR. The AMR team came up with a very nice framework which looked at how does antibiotics used in animals or even when they spill over to the environment influence the emission of greenhouse gases. So we know that when animals are treated, they still release some of these antibiotics as metabolites, which can still influence the diversity of bacteria in the environment, let's say microorganisms in the environment. And the chart given here will show you that some of these microorganisms will die, given in black. Some of them will adjust and develop antimicrobial resistance, and some will, of course, try to be competitive. The net result is that any manure that comes out, of course, with these antibiotics will not be broken down as expected. And so we have noted that there'll be much more release of greenhouse gases, including nitrous oxide, methane, and others. We had a PhD student who did a study really to examine this concept further. And she did an experiment here at ILRI in partnership with our center, which we call Mazingira Center, which usually does measurements of methane and other greenhouse gases. And the student was able to show that when you lace the manure with various types of antibiotics, the ability of bacteria to break down that manure and reduces. The net result will be an increase in the levels of methane that's released. The various bars on the graph, of course, demonstrates the various concentrations of antibiotics that were used. And the letters on the graph also shows that, you know, there's much more concentrations of these gases above the control levels that were used for reference. So that's one evidence from the AMR team showing that, you know, antibiotic use, if not really controlled, can really worsen our ability to minimize the emission of greenhouse gases. The next team, which focuses on zoonotic diseases, also did several studies on linkages between zoonosis and climate. We did some work in Kenya on Coxiella burnetii, which is one of the agents, which is an agent which also causes Q fever. And in humans, the disease causes febrile illnesses, headaches, malaise, myalgia, as well as atypical pneumonia. In animals, the disease is associated with abortions, birth of weak offsprings, and stillbirths. I generated a picture here to show you that this disease is really very prevalent in arid and semi-arid areas where we find sheep and goats, as well as animals like zebras, gazelles being dominant. And of course, the risk factor here would be, which we showed from multivariable analysis, is increase in the wind speed, lack of vegetation, which is shown by lack of shrubs, and some soil types. So at the end of the day, you see this disease can increase, or its transmission might be increased if we have any changes in the wind speed, as well as denudation of areas. That means we should actually be advising policymakers to focus more on replacement of vegetation cover in areas which it's possible, so as to reduce degradation of the environment. The next disease which we did was Rift Valley fever, and this study was done here in Burundi during the outbreak which was seen in 2022. And what we did there is to collect data sets on the number of cases reported by the veterinary department. We also collected climate data sets, including temperature, rainfall. And from this, you can see a strong linkage between the amount of rain as well as temperature 3 months before the outbreak was noted. So the red line here on the graph gives you the dates when the cases were reported. But if you walk backwards at least 3 months before the outbreak, you would see an upsurge in the levels of rainfall and minimum temperature. This, of course, another indication that if we see in future an increase in the frequencies of extreme events, including above normal rainfall, there'll be a very high chance that we get several of such outbreaks occurring. I put in here a note that, of course, that the study was done in conjunction with socioeconomists and gender scientists to determine the impact of the disease overall. The last example of zoonosis is a work that we have been doing on ticks. And this is just a demonstration that in addition to really focusing on the disease itself, we have been trying also to look at the niches of several tick vectors and as well as mosquitoes. So this is showing you Kenya, and there are several stages of tick. This is focusing on the specific tick that transmits a disease called Crimean Congo. The northern region of the country is, of course, very high temperatures, and it looks like the tick really loves or thrives very well in such locations. You can see the oviposition rate, egg hatching rates, mortality rates, and all these development stages really thrive or have very high estimates in those regions. And this modeling has helped us to come up with what we are calling a framework for surveillance, where we say in regions where we have high tick populations, maybe those regions already have endemic stability, and maybe the risk of transmission might be reduced because already animals are immune. And so those ones, you just monitor what is happening. The real risk in such a case is on transition zones, where with increase in temperature, the tick niches will be spreading towards those regions which are not currently affected, but they'll be affected as temperature increases. The last example which I wanted to share with you is work that has been done by the food safety team. They've been focusing on aflatoxins. We have a PhD student based in Rwanda called Adolphine. She has been working on looking at the production of these aflatoxins, and she's trying to include climate variables. And this work is ongoing, and we hope to really do a similar analysis to demonstrate how temperature will increase the production of those toxins. So in a nutshell, this is my last slide, just to say, once we have this evidence coming out, there'll be several opportunities to then do forecasts, and we'll have already a framework which we're looking at what are the changes that we are likely to see. First of all, will be the meteorological variables which are increasing in quantities, but also the frequency of extreme events are expected to increase, as well as the air quality is expected to worsen. The net effect on our ecosystems is an increase in heat stress, increase in movement of animals, as well as shifts in ecological settings, which we see vectors of colonizing new areas which were originally not affected. And lastly, of course, these have major influence on the immunity of the animals that we have there, as well as the frequency of diseases which we expect to see. So I want to stop here so that, because my colleagues who are panelists will be giving much more in-depth discussions on similar work that has been done elsewhere. And my first panelist to come in will be Karadi Wright. Karadi is a chief specialist at South Africa Medical Research Council, and she leads work on climate and health in the country. She's also an adjunct professor at the University of Pretoria and University of Johannesburg, and her research is on environmental health epidemiology to understand how climate change affects several of such climate-sensitive diseases. So welcome, Karadi, and we really we wish you all the best in the presentation.
Thank you very much for the introduction. I hope you can hear me and see my slides.
Yes, we can see your slide.
Excellent. Thanks, Bernard. So it's a great pleasure to be able to meet with you today. It's wonderful to see that we've got so many participants online. I wish I was presenting from the ILRI campus in Nairobi, but I'm here in Pretoria, South Africa. And I'd like to speak with you today about climate change and health impacts with a bit of a focus on Africa. So first of all, just a reminder of why we are experiencing several of these climate impacts or shocks. So the greenhouse effect is something that we actually need. It protects us from becoming too cold. So if we didn't have an atmosphere, then we would have no layer or barrier around Earth to try and keep temperatures within the reasonable range that people can exist. So in fact, that atmosphere is really important. The challenge is that we have been emitting more of the greenhouse gases than are required, and they build up in the atmosphere and then increase the temperatures on Earth. So that, in a nutshell, is one of the reasons why we are experiencing climate change. The evidence for rapid climate change is also compelling. This is now a little bit of an old graph, but global temperature rise is increasing. The surface temperatures have risen already by 1.1, if not more, since the late 19th century, and largely driven by carbon dioxide emissions. And you can see this is a little bit old, but we've had recently some of the warmest years on record. I'd now like to focus in on Africa and present to you a short illustration that is the simulated annual temperature anomalies relative to 1961-1990 climatological average. So in other words, this is not showing you absolute temperature, it's showing you the difference in temperature based off a 1960 to 1990 temperature. And it will essentially be saying each year, is it getting warmer, which would be a +1 or +0.5, or is it getting cooler, which would be a -0.5 or -1. And so I'm going to hit go, and it's going to scroll through these slides. And I think it's important for you to keep an eye on where you live in Africa so that you can get a sense of what we are expecting to see in the years to come. So first of all, we start with the historical past. You can see that in many places, the temperatures were one year cooler and another year warmer. This is very much what we would expect. This is based off actual data. So this is historical past. So there are data from weather stations around the world. In this instance, it would be from climate models that have been verified or validated with ground-based data. As we move past the 1990s and then into the 2000s, it's simulated data using a grouping of climate models. And you'll start to notice that there are more and more of the orange and red. And essentially, this is telling us that the temperatures on average compared to that baseline historic period are now warming between 0.5 degrees Celsius warmer, in some cases now up to 2 degrees warmer than what they were in the historical past. So we're going to go all the way through to 2050. So this model matches quite well what we are already seeing now from the observed data. Of course, when this model was made in 2016 or 2017, we didn't know whether or not it would match, but there's pretty good match between the temperatures that were happening on the ground and what the model had predicted. So now you'll see that most of the African continent is experiencing warming against those baseline values, and this just tends to increase. We're starting to see increases of 4 and up to 5 degrees warmer than that historical period from the past. This is again a good time for you to look at your own country and see how these changes will be happening, and also maybe reflect on what this would mean for you as an individual. It might seem arbitrary to think that 5 degrees on average is maybe not that big a deal, but if it does take you from typically having a 37 degrees Celsius temperature and heat waves, it's going to push you into the 40s. So how does this kind of change impact our health? So climate change, as I've mentioned, is not only about global warming, it's changing other environmental conditions. So we're seeing an increase in extreme weather events, as well as what you might call natural disasters. And because we don't live only in an environment which is of the ecological and the physical environment, we also have social conditions, which we call social determinants of health, which really help us understand how individuals can adapt and cope in these changing environmental conditions. And some people can cope really well, and because they've got all the resources that they need to be able to survive an extreme weather event, but others don't. And of course, many countries around the world don't have good healthcare systems. So if these systems are not in place so that people can go and seek care or treatment when they need it, all of this converges into the health impacts that we are seeing from climate change. These impacts can be both direct, for example, if there's a flood and someone drowns, if there's a heat wave, and if someone has heat stroke and passes away, those are direct. But indirect exposures are things like what we were seeing a moment ago with the wonderful work by OHRECA, where there may be changes in food quality or soil quality, and this affects something down the line, which then has a negative outcome on our health. And then lastly, social and economic disruptions. So especially things like war, drought that may cause war, or political conflict, which again moves people, sometimes causing migration, and these all influence the ultimate health impacts that we are seeing from climate change. When we relate these to Africa, and this is a busy slide, but it's just an illustration that there are so many climate change related health impacts in Africa. And this is certainly not an exhaustive list. I think one that people might find alarming on the African continent is down in the far left bottom corner, storm impacts, and just above that, snowstorm impacts. Here in South Africa, I think it was last year, September, we had an incredibly large snowstorm, very unusual for parts of South Africa, caused incredible disruption. Fortunately, only 2 people's lives were lost. But yeah, just that we've always thought we're a hot continent, but in fact, we may see things like cold snaps and snowstorms in the future. Another important one that we should consider are the mental health impacts that come from a changing climate, both direct, for example, the loss of a home during a flood and what that means to stress, but also the concerns for the future and of your children, and how we are seeing, for example, eco-anxiety in young African people. So what is vulnerability in the context of climate change? I spoke about the social determinants of health. It's a little bit tied into that. So some populations will really bear a disproportionate burden of these adverse health impacts that we are seeing. And the extent to which the individuals, societies, and nations experience the health impacts does depend on their ability to adapt to various stresses. So those 3 things that are really undermining ability to adapt is inequality, the disparities that we see, especially in access to healthcare and environmental injustice. So, for example, for environmental injustice, how in a South African context during apartheid, certain population groups were placed, their houses were placed in locations which were within the 100-year floodlines of rivers. Those rivers are now experiencing flood more often, and the people living there are losing their homes as well as much of their livelihoods. And this is not by choice. It was a decision made by government. These are the groups that we consider to be most vulnerable. We've got children, we've got older adults, people with physical challenges, pregnant mothers, as well as the unborn fetus and infants, people with pre-existing diseases, and people who work outdoors. In the instance of people working outdoors, this is especially worrying in the case of heat stroke. We had 7 farm workers in South Africa die 2 years ago in the Northern Cape province from heat stroke. A combination of hot temperatures, but also because there was no electricity and the generator to bring the water up by the borehole wasn't working, and the workers were dehydrated. So if we want to think about how best to protect our populations, especially those who are vulnerable from the impacts of climate change, we can think about these interventions in 2 ways. We can either mitigate or we can adapt. The mitigation is really about trying to improve our atmosphere and reducing those greenhouse gases and having a better balance at keeping the earth at the right temperature that we need to live within. So this is where we would want to move, for example, from a coal-based economy to a renewable energy economy, have more efficient industrial processes, use eco-friendly transport, and try and eat seasonally based on what's available with less meat. But at the same time, we have to adapt. We need to find more resilient agricultural species. We need to delimitate coastal risk areas and ensure people don't live in them. Entomological, I can't say that today, surveillance is critical, particularly if we're going to see a shift in, for example, where malaria occurs and flood barriers in urban spaces. And some of these overlap. They have both a co-benefit for both mitigation and adaptation. So, for example, increasing urban green areas provides cool shade for people when it's very hot, but also an increase in forestation means that we get more removal of CO2 from the atmosphere. Resilience is something that we need to be able to anticipate, prepare, and respond to these hazardous events or trends or disturbances that are occurring. And if we can really try and improve this resilience, we need to assess how climate change will create new or alter current climate-related risks and think of ways to cope better with these risks. So there's really an interconnective play between vulnerability and resilience, which I've just spoken about before, and this helps us have better coping capacity, but also adaptive capacity. Finally, climate change is no longer some far-off problem. It is happening here, and it is happening now. And if you really think that the environment is less important than the economy, try holding your breath while you count your money. Thank you.
Thanks a lot, Karadi, for that very interesting presentation. We want to encourage everyone, if you have any question, please type that on the chat, and Geoffrey will be picking those questions. We'll have time to discuss those questions towards the end of the webinar. For now, I wish to invite our second speaker, who is Alex. Alex is a veterinarian and wildlife ecologist. He's a principal investigator in CIRAD, who is the PI for this Capacitating One Health in East and Central Africa, COHISA, and PRESOD. In PRESOD, he is the East Africa focal point. He has spent 18 years for CIRAD in Southern Africa, that's in Zimbabwe and Mozambique, and he's well versed using participatory methods to understanding health systems. So over to you, Alex.
Thank you. Can you see my slides and can you hear me properly? Yeah?
Yes.
Okay, thank you very much, Bernard and the OHRECA team for giving me this opportunity. I think we had a a very good introduction about how climate impact the epidemiology of diseases and how climate with the Caroli presentation impact our societies and our health in general. I would like to even take another step, a broader step to that, going beyond the relationship between climate and health and trying to look at other type of elements. Why? Because we currently live in a polycrisis context. So there is climate change, the climate change crisis, but there is also the biodiversity crisis. And to some extent, we can talk also about the food crisis, the water crisis, etc. So I will base my talk on the recent release of an IPBES assessment. IPBES is IPCC for Biodiversity and Ecosystem Services. And they released in December 24 in Windhoek during the last IPBES plenary two major reports, the Nexus report and the Transformative Change report. And I will base my presentation on one of the lead author, Dr. Paula Price's presentation that she gave a few months ago on trying to focus on the biodiversity and health relationship. So an IPBES report is like IPCC, a lot of excellent scientists coming together and trying to produce the facts about the topic they are looking at. And so it's an amazing source of information. You have two outputs. You have the summary for policymaker, which is a small document that is negotiated between the countries and the authors. And you have the full report, which is what the authors have been producing and that has not been negotiated. So this Nexus assessment looked at the interrelationship between 5 Nexus elements: climate change, water, biodiversity, food, and health. And the take-home messages of this report is that those 5 crises are interlinked, but currently our responses are not. Yet solutions already exist. The report reports more than 70 response options that have been applied in different contexts across the world and are there to be taken up, adapted to other contexts. But of course, if we want to address collectively that polycrisis context, we need more collaboration. And here's a link towards the Transformative Change report. So I'm sure that you know what are the direct drivers of biodiversity loss. I wanted here to insist on the linkages between climate change and biodiversity loss. Climate change has a negative impact on biodiversity, but biodiversity has a negative feedback on climate change as well. The best example is the conversion of rainforest in the Amazon or in the Central Africa, for example, into agricultural land. So now, if you look at the indirect drivers that are impacting those direct drivers, well, clearly those drivers are linked to the Anthropocene, which is a new era in which all human activities, including the basis of our economies, the capitalist system, trade, urbanization, the level of consumption in some part of the world, have negative impacts on the direct drivers of biodiversity loss, which are linked also to climate change, and have a negative impact, of course, on most of our living ecosystems, I would say. So if we take, for example, that example of a cascading negative effect on the Nexus elements, you can see to which extent most of them are interrelated. Here, the different elements are categorized by color. You can see the reference at the bottom. If you focus on all the impact that can, all the drivers that can impact biodiversity, clearly, as I just mentioned, one of the green arrows goes back to climate change. So reduced biodiversity has a negative impact on climate change, but you can see also that it has a negative impact on health outcomes, including diseases, but also including human well-being and mental health. So those different nexus elements are interrelated. Any action on one of them will have potential positive or negative consequences on the others. So this is another graph from the report. If we put the different nexus elements against each other, first I want you to see that in terms of the horizontal red triangle, there is a lack of evidence of the impact of health intervention on the other nexus elements. So this is a gap in knowledge in research. However, if you look at the impact of positive or negative interventions on biodiversity, the top row, or on climate change, the last row, you can see that positive intervention can have positive intervention on health, on human health, but negative intervention can have negative intervention on human health as well. So the first message is really this interrelationship between all these nexus elements. What the report and the authors try to do after that is to produce some scenarios for the future. And to start with, I would like you to focus on the last one, which is basically the business as usual scenario. Basically what it says with all these red arrows is that we cannot continue as we are doing now. Okay, so it's called natural overexploitation, but it also linked directly to the direct negative effect on climate change and the climate crisis, the biodiversity crisis that are ongoing have a disastrous and will have a disastrous impact on health, food, water production. Well, water is not evident in the literature yet, but as Karadi has just shown, I mean, this is clearly a path that we need to change. So how do we change this path? One way is to concentrate on one nexus element. So I will take the example of the scenario 4, climate first. In that scenario, we decide that the most important crisis is the climate crisis, and we put most of our resources, human and other resources, into climate mitigation. So you can see that, of course, it can have positive impact on climate. It can have a slightly positive impact on health, but it will have negative, moderately negative impact on food and slightly negative impact on biodiversity. And if we go on, if we follow those scenarios, clearly this is not sustainable. It's the same if we take a conservation first or a food first scenario. It doesn't work as within the global system, basically. So what the report presents after that is more balanced scenarios that have positive outcomes for the 5 nexus elements. So there is a nature-oriented nexus, balanced nexus. I don't want to enter into the details. The main option is that positive outcomes for people and for nature are feasible and include integrated and timely adoption of multiple response options. So once you know that, so there is a pathway, there is a sustainable pathway that can more or less handle, I would say, the different crises, then the report says, and the response options exist. So here you have the response option wheel. So I don't expect you to read all those response options, just to say that they are in detail presented with all the references in the report. And within the more than 70 response options, we have 15 health-related response options that are presented. And those response options, as I said already, they have been tested, they have been validated in some contexts, and so they are there to be scaled up or scaled out in other and different contexts. Just to give you a few examples of those options, I don't have time to get into the details, but forest conservation for health, mangrove conservation and restoration for health, or sustainable use of medicinal plants, all these response options have positive impact on the 5 nexus elements. So to conclude, I would say that first, please, if you don't know the Nexus report, look at least at the policy summary for policymakers and the full report. Also, have a look at the transformative change assessment. Those are key reports for your work in epidemiology, in the One Health space. So the main message here is to say that we need to have a systemic approach. We need to have a holistic approach, because whatever intervention that we think can be good in one sector can have a negative impact in other sectors. And so the only way to have an intervention that are positive across the different nexus elements and try to tackle the different crises that we are currently experiencing is to have a systemic approach working in interdisciplinarity, even in transdisciplinarity, taking into account local stakeholders. And that's exactly what the One Health approach is promoting, especially in its new 2022 definitions by the quadripartite: healthy ecosystems with healthy people, healthy wild and domestic animals and plants. Thank you very much.
Thanks a lot, Alex. That's really timely. That's a good message that as we continue doing our analysis on climate and health, we should be, using the system-wide approach to capture the multiple nexus elements that are relevant. So the last talk, again, I want to remind you, if you have any question, please put those in the chat and Geoffrey will be able to help us later. The last presentation is by Raymond. Raymond is based in Zambia. He's part of the Zambia National Public Health Institute. He serves as the One Health coordinator, and he has been involved in implementing several initiatives on One Health, including IHR PVS frameworks. And we really look forward to hearing from Raymond, because at the end of the day, our interest is also to influence policy in whatever analysis we do. So over to you, Raymond. Share your screen and you'll be able to proceed from there. You are muted. Perfect.
Great. Thank you very much, Bernard. Could you kindly confirm that you can see my screen?
Yep, it's perfect.
All right, great. Just to say thank you again once more for hosting us and inviting us to speak today on this webinar. As introduced, I'm Raymond Hamonga, based with the Zambia National Public Health Institute. And I think away from the science, I will be speaking a little bit to policy with a Zambian perspective today. So just a quick start to start things off, just to give a background about our country, Zambia. We are a land-linked country being surrounded by 8 neighbors around us. And for Zambia, in terms of climate, we do have 3 agroecological zones in our country. We have the rain season. That's just about to start off now. It runs from November right up to April. The dry season, that runs from May to around October, November. And this dry season is further divided into 2. It gives us the hot dry season as well as the cool dry season. And just like most countries, we are indeed impacted. Climate change has been impacting on health systems and has provided various challenges in human development. And I will be getting into some of those in my talk as well. So to look at some of the climate change impacts for us as a country in Zambia, climate change does manifest mainly in increasing temperature and rainfall variability for our country. And this leads to recurring flooding, especially in urban areas due to unplanned settlements, as well as prolonged dry spells that tend to impact water and food security. And additionally, we are faced with a number of climate-sensitive diseases such as cholera, malaria, and also anthrax are a pretty big problem. And the recent literature is beginning to indicate that especially for the northern part of Zambia, could be at risk to Rift Valley fever, even though we have not reported that officially for quite a while. And Zambia as well is a mining country, and therefore environmental degradation and deforestation do play a critical role in how human beings are getting exposed to zoonosis control. And just as an illustration, we did come through out of a very big cholera outbreak, the 2023-2024 period, which was the largest cholera outbreak we've had for over 5 decades, over 50 years. And we had a total of over 700 cases at the peak of the outbreak. And nearly concurrently with that, we also did have anthrax cases that were reported in an area that had previously not had anthrax before. And these two events were preceded by a period of prolonged dry spell. And literature does indicate that dry spell does exacerbate the occurrence of cholera outbreaks. And also additionally, dry spells also predispose the occurrence of anthrax outbreak as well. And now I'm going to switch and speak to some of the ongoing efforts to address climate change on health from a policy perspective. So as a country, we've developed a number of policy architecture, and I will highlight these briefly. So we do have the National Adaptation Plan, which was just launched in 2023. This is a recent document. And we also have a Health National Adaptation Plan launched in 2017. And as I'll speak to this later on, this came to an end already in 2022, and it's one of the oldest HNAPs in the region, and that's because we are working on a new one. And we also do have a national policy on climate change, the NPCC. We also have a national framework for weather and water and climate services for Zambia, which was launched this year. We have a national green growth strategy. And last but not the least, I will be speaking to our national One Health strategic plan. So if we can just delve a little into these policy documents that we have as a country. Beginning with the National Adaptation Plan, this plan it highlights and provides the overarching climate adaptation vision under which the health and other sectors operate. And in this plan, it recognizes health as a climate-sensitive sector and promotes early warning systems and multi-sectoral data sharing. And also the plan seeks to strengthen institutional coordination and financing for resilience. And the HNAP, which I just spoke to briefly earlier on, identifies health risks linked to climate variability. And as I said, in our context, these predominantly tend to be malaria, cholera, and nutrition. And this plan serves as Zambia's health-specific adaptation framework and complements the broader National Action Plan. And as I mentioned, the latest version is under development, and we are concluding our vulnerability risk assessments from the national and sub-national levels and seeking endorsement at policy level as well. And this plan establishes actions for strengthening health systems, adaptive capacities. Then the next plan I'll speak to is the National Green Growth Strategy, 2024 to 2030. And this strategy connects the economic planning with environmental and social resilience goals, integrates climate change, environment, and development planning, and promotes sustainable growth and low carbon pathways. And this plan also encourages investments with health core benefits, that is clean energy, air quality, as well as WASH, which is water sanitation and health. Then the other plan that I'd like to speak to today is the NPCC, the National Policy on Climate Change. And this actually was Zambia's first cross-sector climate framework and remains a cornerstone for policy alignment. In it does provide the legal and policy foundation for climate action and encourages sectoral mainstreaming of climate adaptation, including, of course, the health sector itself, and also establishes coordination mechanism to the National Climate Change Secretariat. And last but not the least, in terms of the plan that we'll discuss today, is the One Health Strategic Plan, 2022 to 2026. So this plan is the one that operationalizes the One Health concept, linking health resilience with environment management and climate change. So in this plan, which was importantly co-signed by the ministry responsible for health, the ministry responsible for the environment, that's green economy and environment, as well as the ministry responsible for animal health, which is the Ministry of Fisheries and Livestock, primarily because these tend to represent the three arms of One Health. In it calls for the prioritization of zoonotic diseases control and climate-sensitive surveillance. It anchors multi-sectoral as well as interministerial coordination through the establishment of various technical working groups. And this exists at the national level, the provincial level, and presently the district level, which is the lowest administrative level, where 50 of the 116 were activated, and the remaining ones are going to be activated between now and December. Now, other aspect that we need to bring about in our context, and I think we need to speak about, is the issue of climate as well as gender. And I think Dr. Wright did speak to this about inequalities and vulnerable populations. So climate change, it worsens our health inequalities in Zambia because of gender roles and equal access to resources and social norms tend to concentrate the risks associated with climate change among vulnerable groups, largely women and girls, and other marginalized groups like elderly. And additionally, practically, this means our climate health plans must do more than just add women to the table and say, well, women were present in this meeting, but rather they must collect sex disaggregated data, protect maternal and child health services during shocks, and prioritize social protection for female-headed households, which tend to be a majority, especially in rural setups. And also, we advocate that we need to fund and scale women-led adaptation activities and ensure that women have real decision-making roles in district national action plans processes. And then simple operation tools like gender-responsive rapid assessment templates, facility checklists to keep maternity services running, and targeted IEC for women, and make policy actionable even up to the district level. So moving away from that, I'd like us to share some of the best practices and lessons that we've learned in our journey as a country. And one of these is to integrate climate and health surveillance. So we are working actively at linking Zambia meteorological data together with that of the Zambia National Public Health Institute disease surveillance to ensure early warning systems. As I highlighted earlier on, we are also using the One Health multi-sectoral coordination to ensure that we can conduct joint risk assessment and also response planning to avoid duplication of efforts. And we've also learned to pre-position climate-sensitive health commodities in high-risk districts, such as cholera, ORS kits, and vector control kits like mosquito nets, to ensure our health systems remain resilient in the face of climate shocks. We're also working actively, this is something we're beginning to do recently, on community engagements and local early action plans that we can sit down and incorporate with the local actors at the various levels. And I will speak to this, including traditional leadership, community leaders as well. And then last but not the least, we are working at capacity building, where we want to train health and meteorological officers on climate health interpretation and risk communication. Traditionally, our MET data has been informing colleagues from the agricultural sector, but there's never been that link between meteorological data with the health system to say, what does an increased NDVI mean, increased vegetation index, or what does high temperature or low temperature mean in the context of health and also vector control? And that's one capacity area that we want to generate. It's nothing as always that is all rosy. We do also have gaps and challenges, and these again continue to manifest in the form of fragmented coordination amongst ministries. Despite the efforts that have been done, we still have a limited integration of climate and health data systems in a real-time sense, and as well as underfunding for adaptation and One Health activities. And last but not the least, there's still weak community level surveillance, awareness, and inclusion. And these challenges do provide us with a number of opportunities, or we propose that we can embed One Health in climate policy implementation and also offer cost-effective, sustainable, resilient gains. And therefore, we think that there's an opportunity for us to strengthen multi-sector governance, especially under our already established One Health platforms. We could also expand climate-informed early warning systems and also embed One Health in the implementation of the National Action Plan and the Green Growth Strategy, and also enhance cross-sector research and data sharing. And again, as I mentioned just now, we need to involve the local actors, traditional leaders, conservation areas tend to also work with a lot of stakeholders that can serve as sentinel sites for early warning. And importantly, data sharing should not always only be top to bottom, but rather it must also work in a way that knowledge, indigenous knowledge, is incorporated along with conventional knowledge that we use. There's a lot of biograms that are available that tend to inform climate shocks ahead of time that have not yet been documented in our conventional systems. So as I conclude, allow me just to speak to some of the country priorities for addressing the impact of climate change on health. Number one is around strengthening a climate-sensitive surveillance for early warning. As I mentioned, to integrate net data with surveillance, public health system surveillance data, as well as to build climate-resilient primary healthcare systems. These are the ones that tend to be on the blunt of climate shocks and getting cut off either due to flooding or due to drought. And also to scale up community preparedness and risk communication. We also want to prioritize the protection of nutrition and food security systems, see how we can link health and agriculture in drought or flood response plans, strengthen One Health multi-sector coordination by conducting joint risk assessments and planning, as well as expanding climate health workforce, training for surveillance, clinical and public health teams. And last but not the least, we need to prioritize financing, planning and policy aligning to ensure that the mainstream health in the National Action Plan or the NCCRS budgeting can be able to mobilize finance. With that, I thank you for your attention. And obviously, I'd like to invite you to visit Zambia if you haven't done so before we lose this natural wonder to climate change effects. Thank you so much, Bernard. Back to you.
Yeah, thanks a lot. And you have given lots of practical interventions that you have been implementing. That actually preempts one of the questions I had in mind on what are the investments we should do now, given that we need to start actively working on climate change even before, when we still have time. So I think as we prepare for Geoffrey to populate questions which are coming up, maybe to start off, we can do, I'll request everybody, every panelist, maybe to put on their cameras and we can do a short discussion. I have maybe one question each. We start with Karadi. And the question that comes to mind is even looking at what we have done here at ILRI, we usually do analysis for climate and health for a disease at a time. So, you know, one day we do one for Rift Valley fever, another day we do one for cholera, another day we do one for another tick-borne disease. Yet we know climate effects are diffuse. It affects multiple diseases at the same time. And how do we have any frameworks or guidelines or some ideas on how we can actually capture the totality of impacts of climate change on health?
That's a really all-encompassing question, Bernard. And I see my internet's a little unstable, but hopefully it'll be okay. So I think there are definitely models that are coming out where you can do, in the same ways you would consider multi-pollutants when you're doing air pollution, where we are looking at multiple exposures. My team in particular have not been doing that. Our work has been doing, for example, the interactions or the modifying effect of temperature on air pollution exposure and respiratory outcomes. we haven't tackled multiple climate-related health impacts in one model. But I do think that's the way we need to go if we want a more holistic approach to how climate can affect health and how best to protect us.
Yeah, thanks for that response. Geoffrey, when you are ready, you can alert me and then we will let you come up with questions. So I have one question for Alex. The Nexus report, which you just shared, is really an encompassing system-wide thinking, which requires us that, we address these questions in totality. The one question that comes to mind is ecosystems are really highly connected. We usually draw artificial boundaries whenever we want to estimate ecosystem services, or even you want to understand how an ecosystem works. So from your perspective, or maybe from the report or your own perspective, how do we implement a Nexus report? Is it better off being done at the national level? Can it be done at a subnational level? Or this is something that the communities can actually be able to look at the various Nexus elements and work out a system for implementation?
Yes, thank you, Bernard. Well, I think there is a need for some actions at all levels. Of course, international levels, but let's go back to the levels you mentioned. National levels, I think it's very important. And especially there need to be the creation of an enabling regulatory environment in order to be able to work in that kind of systemic way at a more local level. Of course, One Health platforms should be a very important group of stakeholders that can promote that enabling environment to work at the local levels. I want to add two things. I'm a strong supporter of local interventions, and therefore I would, if you have a good regulatory enabling environment, as I just said, to let local stakeholders organize themselves and decide themselves what type of intervention they need and how they're going to design it, implement it, and monitor it. I think that this is not a guarantee, but it has a more higher probability, at least, of the intervention being successful and sustainable. And the last point that I wanted to make, you talked about land users. I think it's important to reconnect land users as well. Protected area, for example, should not be disconnected as we have done in the main conservation paradigm. A protected area, a national park doesn't have any activity, etc. Yet those protected areas, those pieces of nature or biodiversity should be able to contribute to the people living around those areas. How do we do that? Well, once again, we need to co-design together, but Karadi is from South Africa, and I remember in Kruger at some point they were organizing some Mopani worm collection by local communities around the park, inside the park. And that had a huge impact on people's well-being, how they reconnect to nature, their mental health, and also their food security. Thank you.
Right. Geoffrey, anything?
So just a question to Alex. And I think this one was, let me see. It has disappeared.
Okay. Yeah, you can look for it. Let me ask Raymond, you talked about a very nice technology there where you said you are ingesting or integrating data from meteorology to disease surveillance systems so that it can then enable you to do kind of real-time utilization of those data from the climate aspects. Could you maybe clarify maybe slightly on how it was developed and how is it being used practically? Do you continually have to check with Met services, or you can run with the system all by yourself in the ministries responsible?
Thank you, Bernard. So with regard to how we are integrating data between the health systems and the Met department, I think I need first to give context that a number of our ministries, I think this is similar across most countries, were designed not to be horizontally integrated, but rather vertically integrated. That means that data goes all the way to the highest level, permanent secretary, before it can be passed on to a sister ministry. So in the writing on the strides we've done in the One Health space of co-signing and having this start coaching to further happening, we said with the informal way of data sharing, and have moved that to develop a platform that we are calling the FISIMS platform, the Public Health Information Management System. And this is a platform that was established through an act of parliament that established the National Public Health Institute. So in there, to deliberately plan to have a platform for data integration for public health security, and that's what we are writing a climate health data upon that. So we've the system is not fully operational, but we have had a lot of benchmarking exercise, seeing what data elements we need to be sharing across sectors, and then writing on an event-based surveillance. We have now an informal way of data sharing in terms of alerts that come from the Met department. So all the alerts that the Met department will issue for a given specific period are shared proactively on Ministry of Health platforms to ensure that we can also plan in that manner. But once the system is fully operationalized and rolled out now, that means that will become a real time with complete with dashboards. And then we can integrate our systems to feed seamlessly into one another. Thank you.
Right. Maybe one follow-up question also, the various policies and strategies you showed. Is there a point where you need to integrate them, or each has to be there to address a specific question?
Sorry, Ben, could you rephrase the last part of the question?
Yeah, so I think you showed us around 4, 5, 6 policies which can be used to address climate and health. And the question I have is are there ways in which you are required to do some integration of some sorts, or you think each and every policy has a specific role that it has to address?
Yes, absolutely. So as I highlighted, some of the policies were raised to incorporate climate in a various number of ways. For instance, you want to integrate climate change impacts in your urban development, and there are some policies that are focused specifically on the health sector, and there are some that are just looking at climate and weather as well. So what we feel is the common denominator in all this is the issue of multi-sectoral coordination and people knowing who's doing what in what sector. And the common base for that in terms of integration is that what brings about the One Health Strategic Plan. Because this is a plan now that anchors all the multi-sectoral players in the climate and health space, and even beyond climate and health to include zoonotic diseases, to include aspects of environment surveillance, so that we all come in to speak in one space. Because what initially we had was where when you say multi-sectoral meeting in the health, each thematic area would call basically the same people, and they come in and they wear a different hat to say, now I'm coming from the environment, but for climate. Now I'm coming from the environment, but for zoonotic diseases. And yet it's the same person. So by anchoring all these plans in the One Health Strategic Plan, it means we don't have to duplicate those various efforts.
Thanks. Geoffrey, you try again.
So Bernard, we have a couple of questions. So the first one is to Alex. And the question is, what has been done on integrating animal health to IPCC guidelines? And then the other one is to you, Bernard. What lessons have emerged from integrating climate models with disease surveillance systems? And this other one is to Karadi. What communication or policy strategies have been most effective in translating health data into climate action. And then there's another one in the chat that says traditional One Health models often focus on the environment, animal, human triad in relatively stable settings. How must we adapt this framework to effectively address the quadruple burden where climate change acts as a catalyst for conflict, thereby collapsing the environment and health systems we aim to protect, as we see in Sudan?
Right. Maybe Alex, you can go first.
Yes, thank you. So for the IPCC, I must say I don't know. But if the question was about health in the IPBES, what I've talked about, I think human health in its two dimensions, meaning human diseases and human well-being, I would say, or mental health, is present in the IPBES framework, because one of the main outcome of the IPBES framework is good quality of life. And clearly, good quality of life encompasses being well physically, but also mentally, and so talks to mental health. The interesting thing is that the Nexus report I've just mentioned, so clearly one of the Nexus elements is health, and it is human health specifically. And so IPBES is much more younger than IPCC. It was created in 2013. They did one global assessment of biodiversity, so their major work that was out in 2019. And they are starting now the next global assessment that will be out in 28 or 29. So the second global assessment of biodiversity. And clearly, these new assessments will harvest all the information that have been produced in the previous report, including the Nexus report. And so clearly, the outcome of human health, but also the One Health approach will be clearly much more central, maybe not central, but much more considered than it was in the first global assessment.
Right. Thanks. Maybe as somebody else is thinking about the other questions, I can address one on modeling and surveillance. I can use an example that we noted recently, whereby surveillance data can be very misleading. You know, you report cases where you have seen them, but actually cases occur even in other places where there are poor access to services, poor access to hospitals or even veterinary officers. And so it helps you, a model will help you to see risk in entirety, see risk in terms of where else we should be putting our efforts in trying to understand. Give you an example of a dengue fever in Kenya, where it's usually reported in the coastal region. But when you do niche models or even prediction models for other suitable locations, you find there are other locations in the country where actually services or even health services should be paying more attention in terms of uncovering risk. Models can also help us to develop those timelines in a much more evidence-based manner. Usually what we do in veterinary services or even medical services is we tend to wait too long, or we tend to wait until we actually see the initial cases of a problem. Whereas in models, if we can use things like climate data, you might actually buy time, get a much longer lead time to enable you implement something. So they really play a huge role. And I really like the example which Raymond is giving for Zambia, where we can move towards embedding those models into the routine surveillance systems so that then it can help in decision making. That's the much I can say for now. Maybe let me pause for somebody else to address the other questions which Geoffrey was raising.
I can maybe go for the one on the chat, the traditional One Health models. Yes, clearly, I think that what I've tried to present in terms of the polycrisis context is really getting into more complex system, and I think that's exactly what you're trying to look at. I think the traditional One Health models were looking more at what are the synergies between the human health and the animal health sectors that can be looked at, with climate change being taken into account since a long time, but much more just, in bracket, as a driver on the system. Now, when we look at the new context now, climate change is not only a driver, it's something also on which we can have an impact. And it's the same for biodiversity. And biodiversity needs to be in the equation. I don't know Sudan, but I'm sure you have huge rangelands in which you have people living with a livestock, and therefore rangeland management and conserving the biodiversity of rangeland is crucial. And for example, soil biodiversity, we know now that it's more than 60% of the global biodiversity. So how do we take those externalities in and try to address, systems that are much more complex? So it's more complex, but the outcome could be more efficient. So it's a challenge, but that's how it should be done. Thank you.
There is a pending question on applying One Health in a conflict environment or scenario where things are really in a flux and we really need to find solutions to address them. And I think the question also addresses like Sudan. So that's really where really One Health is really needed. And I don't know amongst the panelists who has an immediate response as we think about it.
Yes, colleagues are thinking to that. I was just beginning to respond to the question again raised, Bernard, on the chat about what capacities do countries most need to strengthen to deal with climate health risks. Can I speak to that briefly?
Mm-hmm.
Yeah. So I was just going to type that in the chat that we need to speak to, when you talk about climate and health, many a time, I think the focus tends to go to diseases that result as a result of climate change. I think Karadi it highlight that as one of the impacts that come out as well. But in building resilient health systems, you need to look also what also happens to the health system as a result of climate shocks. So for instance, flooding. Immediately the flooding comes, how do we have continuity of essential services, health services to the population during a flooding example, or during drought itself, or during disruption of a road and the clinic is cut off? And therefore, the things that we need now to begin to focus on are twofold. Number one, we need to look at early warning systems. So as much as health facilities and most of the time it's the primary health facilities conduct disease surveillance, there has to be also surveillance around climate impacts. So when temperatures are switching and they are rising, I like the model you showed earlier on about Burundi, where you had that the peak in temperatures right before the outbreak was peaked. If our surveillance system can be integrated with surveillance coming from the Met Department, it means we're able to predict those effects of disease shocks of climate change themselves. And secondly, it's about infrastructure itself. We need to come to a point where facilities are capacitated with infrastructure that is climate sensitive. Things like solar panels that do not have to depend on the traditional grids when power lines fall due to flooding. That's something that health systems need to start investing in as well, and including things like water sources as well that are on site and not depending on piped water from a central location. All those are examples of climate resilient infrastructure that countries need to begin to develop into. So we up our game around surveillance system, integrate with our colleagues from the Met and Environment, can help us predict climate shocks well in advance of time. Those are my contributions.
As Geoffrey picks other questions, I had one question for Karadi. Looking at Africa, and the focus of your work basically has been on Africa. the capacity to analyze data and use climate data is really limited because, you know, most of us are not really versed with, first of all, where do we get this data, which really helps us to see climate change. And if you are able to get that data, it also comes in formats which are really difficult to manipulate. You are dealing with NCDF files or raster files. You have to have specialist skills for you to, first of all, extract the data before you can actually apply. So that means we have left that work to very small clique of people who can do that. Yet the rest of epidemiologists who actually have the knowledge on analysis don't participate that much because of access and manipulation of data. So beyond the trainings that we usually do in workshops, beyond, you know, making these things available, what else can be done to make such data available and hence encourage more people to contribute to climate change analysis, climate and health change analysis?
Thank you, Bernard, for that extremely complicated question. It's not an easy one to answer, and I think I have to precede any attempt of a response by agreeing with you that the data sets are complicated. They are not always accessible, especially health data. Health data are usually behind walls that require not only ethics clearances, but also government permissions. And because we are all frantically trying to generate the evidence that we need to lobby for change in our own African country, we are all doing this perhaps in an ad hoc manner rather than in a way that would promote coherence and collaboration. At the same time, those people you were speaking about who know how to use the data are also sitting in a very special seat, which means that they get hold of the data that, you know, that is actually quite precious to countries, and they can then go and do whatever they like with it. So people then become quite wary in sharing data. And I certainly know that in some of the international projects that I'm working on, the process of getting data sharing agreements signed by multiple institutions is quite a nightmare. So I was thinking about what we could do to change this, and I'm not sure if any of these ideas are totally feasible or would be acceptable in a competitive science world, which is what many academics are working in, all fighting for the same research funding from the Wellcome Trust or from wherever they're applying for funding. But I do think that there's some potential for data, especially free data, to be made into a format that's available and housed in a climate health data hub. So having an offering of pre-processed data sets and perhaps visual dashboards. So for example, in South Africa, we are working on a climate health dashboard. My purpose there is to really be able to show the connections between climate and health. There'll be visualizations that you can make. You don't necessarily get access to the data, but you can create plots that would be informative for presentations. The goal there is not for necessarily the academic or the researcher, but for the policymaker and decision maker or even funder. But something like that, but where these pre-processed data sets are then available in a more readily learnt format. And that said, nowadays there are a lot more materials online of videos to learn how to use different code and different packages to be able to work with such data sets. But I agree, this is something that goes beyond a workshop. Workshops are not going to solve our problems. Then I do think there's a space for MOUs or data sharing agreements. And this is especially important when working with your atmospheric scientists and epidemiologists and biostatisticians, especially from different countries, because they all have different expertise. They don't know the models necessarily that are needed in the climate and health space. But as I said earlier, getting these data sharing agreements signed is a challenge. And then I think we should probably all agree that we should adopt the FAIR principles, FAIR principles, and really have some kind of standardized template for how we are going to collaborate in this space. I don't think anything like that exists at this point, but I'm sure that if there was something, maybe something that the academies of science could do across the NASAC, for example, that we could abide by, at least in principle, I think that would go a long way.
Yeah, thanks a lot. I think we are coming now towards the last 4 minutes of the webinar. I want to check with Geoffrey if you have anything to add, or
I think Bernardo, we're good. I think most of the questions have been answered. Actually, all of them. Yeah.
Right. Okay, so I think maybe we just give each person just the last minute to wrap up, and really from the topics that you are addressing, maybe if you can capture one thing for the way forward, things, the next steps, or things that you really can recommend as we go along with analyzing all this information for climate and health. So let me start with Karadi again.
Thanks. Yes. So I think as if we have researchers on the call, and I hope there'll be lots of postgrad students who are hearing this, it's really important in the climate health intervention space to co-design your projects with the people or the communities and the decision makers and the policymakers at the conceptualization phase of your project. This will mean that the likelihood of success for implementation of whatever intervention you want to try and roll out will have a higher chance of sticking. If you impose something far down the line after the research is done, it's not going to stick. So co-design, co-conceptualization are critical.
Thanks a lot. Co-design. Alex?
Yes, thank you, Karadi. It's part of my take-home message as well. I must say that we are a lot involved in also using so participatory methodology, foresight, trying to make sure that local stakeholders, where you implement the intervention, agree on a future. Where do they want to be in 20 years, 30 years time? And then they can start thinking about what they can do today to go that direction and avoid that direction. And I think in that process also, we need to include biodiversity. Biodiversity is at the source of food production, our mental health, and our health as well. So it cannot be an externality anymore. And I think going back to local and traditional knowledge, it is there. I mean, they have always taken care of their ecosystems because they were depending on them. So I think that is also one of the very important message. Thank you.
Thanks a lot. Raymond?
Oh, thank you very much. And just also to mention that I'm happy with Alex and Radi's. I think those are very insightful presentation. I also benefited as a panelist nonetheless. But for me, my key takeaway messages, I think, in the space of building climate resilience infrastructure, we need to understand that traditionally, medical personnel, whether vets or doctors, tend to be so disease focused. And I think what climate change is entailing is that we need to think outside those traditional silos, and we see what surveillance does not just entail surveillance of diseases, but surveillance of early warning systems and triggers that highlight the impacts of impending climate catastrophes. And this can either be in the form of meteorological data, or they can be in the form of indigenous knowledge as highlighted. So work with everybody, as Karadi mentioned earlier on. Thank you very much.
Thanks, everybody. Thanks a lot. For me, the parting point would be, of course, we have lots of data now in OHRECA, and we are happy we have your contacts. I think all those ideas and suggestions you have given, we hope to, come back to you and we work with you. We are remaining with a few things to do these forecasts and see how climate change would influence the few health challenges that we are addressing. And in a nutshell, all the things you mentioned would really fit very well. I also really like the technology that you're working in Zambia, where you can actually use a system that combines data from several sectors. So I don't want to take much more time of everybody. Thanks a lot. We hope to see you again. Remember, we said we have the last webinar on 12th of November, when we will discuss the impact of OHRECA. So bye-bye, see you again.
Bye. Thank you.
Bye-bye. Thank you, Bernard.